Okay. The clock seems to be right. The subcommittee will come to order. Chair will recognize himself for an opening statement. Medicaid was designed as a safety net for the most vulnerable Americans, including pregnant women, dependent children, the blind, and the disabled. With more than 72 million Americans, or nearly 1 in 4, enrolled in Medicaid at some point in fiscal year 2012, we need to closely examine the quality of care the program provides, reduce the cost of the program to both the federal government and the states, and encourage bold new state solutions to better serve this population. Those enrolled in Medicaid today face significant difficulties in accessing care. According to a recent analysis, while 83% of physicians are accepting Medicare patients, only 70% of physicians are accepting those in the Medicaid program. Other studies have shown that compared to those with private insurance, Medicaid beneficiaries find it more difficult to schedule follow-up visits after initially seeing a doctor, are twice as likely to report difficulty in accessing primary care services, including prevention services, and are twice as likely to visit the emergency room. Clearly, we are failing those most in need of our help. And we're spending enormous amounts of money for substandard care, and in some cases, worse outcomes than those with no insurance at all. On average, states are spending approximately 25% of their budgets on Medicaid, and this percentage will only grow as the Affordable Care Act's Medicaid expansion goes into effect in many states in 2014. In my home state of Pennsylvania, we are already spending nearly 1/3 of the entire state budget on Medicaid alone. This crowds out investments in transportation, education, public safety, and other vital areas. And over the next 10 years, the federal share of Medicaid expenditures is estimated at $5 trillion, with states spending nearly another $2.5 trillion over that same time. Medicaid is in trouble. It has been on the Government Accountability Office's high-risk list for nearly 2 decades, and the Office of Management and Budget reported nearly $22 billion in improper Medicaid payments in 2011. But we don't have to settle for subpar care or limited access and exploding cost. Many states have embarked on innovative Medicaid reforms to improve the quality of care and modernize their programs, ranging from payment incentives to coordinated care to consumer-driven options to added services for their beneficiaries and more. This has been possible in part through the use of state demonstration waivers, but it can take years for the Centers of Medicare and Medicaid Services to approve these waivers. We need to provide states with the flexibility to pursue these options, not lock them in a one-size-fits-all model dictated by Washington. Several reforms have been outlined by this committee in a recent policy paper issued by Chairman Upton and Senator Hatch. The Making Medicaid Work Blueprint is a product of significant input from the states that merits bipartisan consideration and legislative action. I look forward to hearing from our witnesses today. Thank you, and I yield the remainder of my time to the Vice Chair of the subcommittee, Dr. Burgess.
I thank the Chairman for yielding. We're here today to discuss Medicaid, and of course Medicaid is a shared federal and state partnership, but there are wide differences amongst the states with the population served, and thus underscores the need for flexibility within the program's administration. But as we ensure flexibility, we certainly cannot ignore the problems that have perpetually plagued the Medicaid system, including insufficient access to care for beneficiaries, lack of continuity of care, and rapid growth in the program costs. And I would add to that, as the Chairman rightfully mentioned, the difficulties with diversion of funds for activities which might be deemed as inappropriate. I applaud the way the states have implemented innovative reforms, but state flexibility will not solve all of the problems that we face. One of the biggest is Medicaid reimbursement. Medicare reimbursement rates are already embarrassingly low, forcing many providers to refuse new Medicaid patients. In Texas, only 31% of physicians in Texas currently accept new Medicaid patients. This trend only foreshadows the threat to access for millions of new Medicaid beneficiaries beginning next year. To sustain provider and plan buy-in, we must demand accountability from both the federal and state partners. That's the purpose of this hearing today. That's what we're investigating this morning. Certainly look forward to the testimony of our witnesses, and I'll yield back to the chairman.
Chair, thanks, gentlemen. Now yields 5 minutes for an opening statement. The ranking member is Plone.
Thank you, Mr. Chairman. More than 70 million Americans depend on Medicaid services every year, and recipients are often low-income families or individuals with disabilities with long-term needs who would otherwise not have access to insurance because it's unaffordable, unavailable, or inadequate. Providing affordable health coverage is crucial not only to protect the vulnerable population, but also to keep health care costs down. By providing affordable, essential health benefits, emergency room visits and hospitalizations, which are more expensive, can be reduced. I fought hard to make sure that the expansion of Medicaid was included in the Affordable Care Act because it will not only improve access to health care for individuals across the country, but it will improve states' economic health as well. While we expected all states to participate in the Medicaid expansion because it's an advantageous fiscal arrangement, I am troubled and discouraged that there are many who still have not decided to expand. I do believe, however, that eventually all states will recognize the importance of this provision to the healthcare system as a whole. Nearly half of all states recognize that the Medicaid expansion under the ACA is a good deal and have indicated that they will expand. And I anticipate that our witness, Mr. Joe Thompson from Arkansas, will share with us why his state opted for expansion. And let me tell you that from New Jersey's perspective, expanding Medicaid just makes sense, and that's why Governor Christie chose to expand. It will save New Jersey billions of dollars while providing care to an estimated 300,000 new Medicaid beneficiaries. With all of New Jersey's pressing needs right now, it's assuring that the billions in savings will help us to devote more resources towards building our economy and creating jobs. Now, while Republicans will tell you that states need greater Medicaid flexibility, I would argue that under the current law, a great deal of flexibility exists, while simultaneously providing a baseline of protections for beneficiaries. States have the ability to manage the design of their Medicaid programs. Within federal guidelines, they can alter benefits or change cost sharing and premiums. The concept that states have significant flexibility in the management of their programs is reflected by the fact that states, when they want to, are taking on innovative approaches to improve their Medicaid programs. For example, states are experimenting with programs to reduce expensive and unnecessary hospital readmissions, programs to improve health and promote prevention, and medical home models as well. So let me talk for a moment about the Republicans' proposal, which I believe has been presented under the guise to provide greater flexibility. I'm extremely concerned that their proposal will simply lead to higher premiums and greater financial burdens on low-income elderly or disabled Medicaid beneficiaries. Their call for block grants or a per capita cap on future Medicaid funding would reduce federal beneficiary protections currently in Medicaid, since states would be permitted to eliminate benefits or restrict enrollment eligibility. While examining costs and exploring the relationship between the federal government and states is clearly important, we must be sure that we do not strip away protections for Medicaid recipients who depend on the program for access to quality, affordable health care. And thank you, Mr. Chairman. Before I yield, I'd like to ask unanimous consent to enter into the record an article or testimony, I should say, from Carter C. Price from the RAND Corporation on expanding Medicaid and the financial options for states. I
Without objection, so ordered.
Thank you, Mr. Chairman. I yield back the balance of my time.
Chair, thanks you, gentlemen. And now recognize the chair of the full committee, Mr. Upton, 5 minutes for an opening statement.
Thank you, Mr. Chairman. You know, it's been 50 years since President Johnson signed the 1965 Social Security amendments into law, and as many historians have noted, Those high-profile negotiations centered mostly on Medicare, with Medicaid out of the spotlight. While Medicaid covered approximately 4 million people in the first year, there were more than 72 million individuals enrolled in the program at some point in FY12, nearly 1 in 4 Americans. These enrollment figures on their own and their potential drain on the quality of care of the nation's most vulnerable folks is cause for alarm. But once the President's health care is fully implemented, another 26 million Americans could be added to the already strained safety net program. Medicaid enrollees today face extensive difficulties finding a quality physician. On average, 30% of the nation's doctors won't see Medicaid patients. And studies have shown that Medicaid enrollees are twice as likely to spend their day or night in an emergency room than their uninsured and insured counterparts. Instead of allowing state and local officials the flexibility to best administer Medicaid to fit the needs of their own populations, improve care, reduce costs, the federal government has created an extensive one-size-fits-all maze of federal mandates and administrative requirements. With the federal debt at an all-time high, closing in on $17 trillion, and states being hamstrung by their exploding budgets, the Medicaid program will be increasingly scrutinized over the next decade. In future, ability to provide coverage for the neediest kids, seniors, and disabled Americans will depend on its ability to compete with state spending for other priorities, including education, transportation, public safety, economic development. Energy and Commerce Republicans remain absolutely committed to modernizing the Medicaid program so that it is protected for our poorest and sickest citizens. We will continue to fight for those citizens because they are currently subjected to a broken system. The program does need true reform, and we can no longer tinker around the edges with policies that add on the bureaucratic layers that decrease access, prohibit innovation, and fail to provide better health care for the poor. In May, last month, Senator Hatch and I introduced Making Medicaid Work, a blueprint and menu of options for Medicaid reform that incorporated months of input from state partners and policy experts from a wide range of ideological positions. My hope is that this morning's hearing is the next step in discussing the need for reform so that we can come together in finalizing policies that improve care for our most vulnerable citizens. Washington doesn't always know best. We've got to learn a lot from the states, and that's what this is all about, and I yield the balance of my time to Dr. Cassidy.
Thank you, Mr. Chairman. For 20 years, I have treated patients in a safety net hospital. For 20 years, I've seen politicians overpromise and underfund. And as they do so, it is the patient that suffers. Now, the federal government spends almost half of every dollar on health care payments for Medicare and Medicaid. These programs are breaking federal and state budgets, and they are unsustainable in current form. On behalf of my patients, I know that we must change them so that they become sustainable. Now, in Washington, Medicare reform has been greatly considered, but thoughtful solutions for Medicaid, not so much. Now that Obamacare has added 20 million Americans to the Medicaid rolls, it is imperative that Congress begin to address the sustainability of this important safety net program. Now, I will say I think that states are the best innovators for cost containment, far better equipped to offer thoughtful solutions addressing unique patient needs. One size does not work. The federal government should construct thoughtful incentives encouraging states to take an active role in restructuring Medicaid. I'm pleased that the Energy and Commerce Committee has started to shed light, beginning with this hearing. I look forward to hearing from the witnesses today, and I yield back.
Chair thanks the gentleman. Now recognize the ranking member of the full committee, Mr. Waxman, 5 minutes for opening statement.
Thank you, Mr. Chairman. I want to thank you for holding this hearing. I welcome and look forward to hearing from all of our witnesses today. I'm particularly interested in the testimony from Mr. Thompson of Arkansas and how his state has been working to reform the delivery system and how the Affordable Care Act will positively affect his state's residents. There are different paths we can take to ensure long-term health and to promote innovation and efficiency within the Medicaid program. States can and do innovative actions today, and they do it without undermining critical protections for patients. On the other hand, what my Republican colleagues have proposed in their 2 recently released reports is a cost shift to the states, patients, and providers, and abdication of federal responsibility. Block grants, per capita grants, and increases in beneficiary premiums and copays do not reduce health care costs. They simply shift those costs onto the beneficiaries, the providers, and the states. And they make it less likely that people will be able to access care when they need it. The Medicaid program operates with efficiency. Medicaid costs are nearly 4 times lower than average private plans. Over the next decade, annual Medicaid per capita costs are expected to grow by only 3.2% compared to the 6.9% in the private market. Additionally, the Congressional Budget Office's most recent estimates of projected Medicaid spending have dropped by $200 billion through 2020. This refutes the claim that burgeoning Medicaid spending is compromising the program's mission and therefore necessitates funding redesign and cost shifting to our nation's most vulnerable. Let's face the realities at hand and not miss. The issues are that millions of Americans who were previously shut out of having insurance, particularly the working poor, will now have access to Medicaid coverage beginning in 2014. Unfortunately, a number of states have not yet opted to provide insurance coverage for their residents. A RAND study estimates that these states will leave 3.6 million people uninsured, and these people will continue to seek high-cost service in the emergency department of a hospital and experience increased hospitalizations from lack of primary and preventive care. As a result, the study estimates that the state should expect to spend $1 billion more annually on uncompensated care. So much for the states that choose not to cover their very poor people under Medicaid, even with 100% federal financing for the first several years. And there are things we could do to improve the program. Certainly, for example, we should extend the Medicaid primary care payment increase that is helping bring Medicaid rates on par with Medicare rates. Any member concerned about access to doctors for Medicaid beneficiaries should surely embrace that. Additionally, we can continue to improve care for the dual eligibles, who comprise 15% of the Medicaid population, but account for nearly 40% of its expenditures. We can target prevention, including obesity and smoking, to keep people healthy. The alternative path we began in 2010 with passage of the Affordable Care Act is entitlement reform in a thoughtful way through delivery system reform that improves both efficiency and quality. The Affordable Care Act includes incentives to reward physicians and other providers for better coordinating care and improving health. It also includes policies to cut waste and inefficient care, but above all, it improves access to care, particularly preventive care, and that saves dollars and lives. Reviewing the facts, we see that health reform is entitlement reform. It is this kind of reform that builds a better health care system for all Americans at the same time that it lowers costs and helps support the long-term sustainability of our public health care programs. Thank you, Mr. Chairman. Yield back the balance of my time.
Chair, thanks, gentlemen. That concludes our opening statements. We have one panel with us today, 3 witnesses. I'll introduce them at this time. On our panel today, we have Ms. Sema Verma, consultant with the Strategic Health Policy Solutions. We have Dr. Joseph Thompson, Surgeon General of the State of Arkansas, Director of the Arkansas Center for Health Improvement. And we have Mr. Tony Keck, Department of Health and Human Services from the state of South Carolina. Thank you each for coming. Your written testimony will be made a part of the record. You'll be given 5 minutes to summarize your testimony. So at this time, Chair recognizes Ms. Verma for 5 minutes for opening statement. Red light on.
Okay. Good morning, members of the committee. My name is Sema Verma. I am the president of SVC Inc., a policy consulting company, and in this role have been advising governor's offices, state Medicaid programs, and state departments of health and insurance. I have worked in a variety of states, including Indiana, South Carolina, Maine, Nebraska, Iowa, and Idaho. I am also the architect of former Indiana Governor Mitch Daniels' Healthy Indiana Plan, the nation's first consumer-directed health plan for Medicaid beneficiaries. Designed in 1965 for our most vulnerable populations, the Medicaid program has not kept pace with the modern healthcare market. Its rigid, complex rules designed to protect enrollees have also created an intractable program that does not foster efficiency, quality, or personal responsibility. The impact of these issues is more pronounced as states are entrenched in the fierce debate around Medicaid expansion. Reluctance to expand is not indifference to the plight of the uninsured, but trepidation for the fiscal sustainability of the program and knowledge that expanding without reform will have serious consequences on Medicaid's core mission to serve the neediest of Americans. Medicaid comprises nearly 24% of state budgets, and its costs are growing. This is due to growth, population demographics, and federal requirements. The aging baby boomer population will soon require expensive long-term care. The Affordable Care Act requires maintenance of effort and implementation of hospital presumptive eligibility, modified adjusted gross income, which eliminates asset tests for the non-disabled, and the ACA insurer tax will cost states an estimated $13 to $14.9 billion. Additionally, there is the clawback provision burden, where states have an unprecedented requirement to finance the Medicare program. Despite growing outlays of public funds, a Medicaid card does not guarantee access or quality of care. In a survey of primary care providers, only 31% indicated willingness to accept new Medicaid patients. In 2012, 45 states froze or reduced provider reimbursement rates. Medicaid access issues are tied to undercompensation of providers. On average, Medicaid payments are 66% of Medicare rates, and many providers lose money seeing Medicaid patients. Medicaid beneficiaries struggle to schedule appointments, face longer wait times, and have difficulty obtaining specialty care. These access challenges will be more pronounced as Medicaid recipients compete with the tens of millions of newly insured under the ACA. Studies also show Medicaid coverage does not generate significant improvements in health outcomes, decrease emergency room visits or hospital admissions, and participants have higher ER utilization rates than other insured populations. At Medicaid's core is a flawed structure. While jointly funded by the federal and state governments, it is not jointly managed. States are burdened by federal policy and endure lengthy permission processes to make routine changes. Notwithstanding the cumbersome procedure, 1115 waivers provide a pathway for state innovation. However, the approval route is so daunting that states often abandon promising ideas if a waiver is necessary. Absent are evaluation guidelines, required timelines, and there is a capricious nature to the approvals as waivers do not transfer from one state to another. Even with positive outcomes, a new administration has the authority to terminate a waiver. Despite intense federal oversight, results vary substantially, and there are no incentives for states to achieve quality outcomes. For example, the average cost to cover an aged Medicaid enrollee is roughly $5,200 in New Mexico versus almost $25,000 in Connecticut. And annual growth rates also vary. Replacing oversight of day-to-day administrative processes, the federal and state government should collaborate to identify program standards and incentives. States should be provided with flexibility to achieve these goals, and successful states should be rewarded with reduced oversight. Medicaid's uncompromising cost-sharing policies are illustrative of a key failure. These regulations disempower individuals from taking responsibility for their health, allow utilization of services without regard for the public cost, and foster dependency. While some policies may be appropriate for certain populations, in an era of expansion to non-disabled adults, they must be revisited. Revised cost-sharing policies should consider value-based benefit design and incent enrollees to evaluate cost, quality, and adopt positive health behaviors. Indiana's Healthy Indiana Plan waiver applied principles of consumerism with remarkable results, lowering inappropriate ER use and increasing prevention. Congress should reform Medicaid to assure long-term fiscal sustainability and access to quality services that improve the health of enrollees. A fundamental paradigm shift in management is required, and the program should be re-engineered away from compliance with bureaucratic policies that do not change results to aligning incentives for states, providers, and recipients to improve outcomes. States are positioned to develop policies that reflect local values of the people they serve and should be given the flexibility to do so. Thank you.
Chair thanks, gentlelady, and now I recognize Dr. Thompson, 5 minutes for an opening statement.
Thank you, Mr. Chair, members of the committee. I'm Joe Thompson. I'm a pediatrician, member of the faculty on the University of Arkansas for Medical Sciences faculty. I direct the Arkansas Center for Health Improvement and have served as the lead cabinet-level advisor as Surgeon General, first under Republican Governor Mike Huckabee and now under Democratic Governor Mike Beebe. Had the opportunity to work with 2 administrations in the federal government. Our entire healthcare system has changed dramatically over the last 5 decades since the inception of Medicaid, with increased therapeutic and diagnostic opportunities, increased treatments. The costs have grown, and with that have grown the cost on both the public and the private sector. Our private sector costs in Arkansas have doubled over the last decade, from $6,000 to $12,000 for a family of 4's premium. The costs have also increased for Medicare and Medicaid. As you have discussed, I want to commend this committee. The Medicaid partnership in funding for states and federal governments is under intense duress and significant tension. But I would like to back up. It is not just a Medicaid problem. Our entire healthcare system is under a cost threat that threatens our families, our communities, and indeed the economic vitality of our nation. It's not a new issue. It's been growing, but suddenly we're forced to face it. And if I can, we started off with private insurance, largely through employers, and Medicaid for the vulnerable, the poor, and the disabled. I'll leave Medicare off because that's not the topic of your discussion. Over time, as we grew the therapeutic and diagnostic opportunities, we grew the ability to do things to and for people, and the cost grew, and the valley of the uninsured, people who could not afford care, grew also. So we started having more and more uninsured individuals. Private costs went up, but the private employers or affluent families could continue to afford those costs. The Medicaid program did not keep pace with those costs, and the federal government nor state government budgets could afford it. And so we end up with a huge, large valley of the uninsured. We end up with expensive private insurance that some can afford, and we have Medicaid programs that cannot afford either on the federal or the state budget. So we end up with what is a problem of the iron triangle: cost, access, and quality. If we're not willing to pay, we're going to have access problems. If we have access problems, we suddenly have quality problems. This is not a single issue about Medicaid. This is a systemic issue about our failure to gain control of the rapidly rising health care costs that have outpaced federal and state budgets, that only a few employers and families are able to continue to afford, and that have grown the valley of the uninsured. So with that backdrop, let me share with you our experience in the state over the last 10 years. As of last year, we were operating 9 different waiver programs designed by the state and approved by the federal government to provide Arkansans with better access, higher quality, and more cost-effective care. Under the past administration, President Bush's secretary successfully supported our proposal to develop a waiver for support of small businesses, for businesses with fewer than 10 employees who virtually had no option for private employer-based health insurance coverage. This small business support was entitled the AR Health Networks program. It was a low-cost, limited benefit program, largely successful at maximum uptake. It will be absorbed into the Affordable Care Act now for small business support going forward. But we started that in 2005, 8 years before the implementation of the Affordable Care Act will go into place. 3 years ago, we started to tackle the issue of cost containment. Our governor, our private sector recognized that the costs and the fee-for-service system were largely the cause for outpacing the growth potential of our revenue streams. So we undertook Payment Improvement Initiative, led by Medicaid, which changed from a fee-for-service system to an outcomes-based incentive system with upside and downside risk for providers based upon what the outcome of the patients were, so that there would be engagement with patients. This required federal government approval, which we got through a state plan amendment within 2 months. It was an achievable goal because it was a programmatic need. More recently, our Republican legislature and the General Assembly, with the governor's support, authorized use of the Affordable Care Act Medicaid programmatic funds to offer a totally new premium assistance program to buy health insurance premiums through the health insurance exchange, not to expand the Medicaid program in the traditional way. Essentially to fill that valley in with private insurance, not to expand a state-run Medicaid program fraught with some of the issues that Ms. Verma alluded to. We will need to get a streamlined waiver from the administration this summer. We've already started on that, and we have not identified a barrier to being able to do that at this point. So moving forward, we anticipate that of our 25% of the uninsured, we may have as many as 250,000, or almost 8% of our population, not be in the Medicaid program, but be in the private health insurance program. In conclusion, our state's not alone. Other states need help, but it is a partnership based upon a long-term history that must be brought into the 21st century, not abandoned because we didn't bring it into the 21st century. Thank you.
Chair, thanks, gentlemen. And now recognize Mr. Keck, 5 minutes for an opening statement.
Good morning, Mr. Chairman and members of the subcommittee. My name is Anthony Keck. I'm the South Carolina Director of Health and Human Services, the state Medicaid agency. I appreciate the invitation to discuss my thoughts on improving health through Medicaid. While we don't run a $6 billion agency on anecdote, I'd like to share a simple story with you that sums up our common challenge. I once ran a community clinic in a poor but vibrant and politically active New Orleans neighborhood known as the St. Thomas Irish Channel. During that time, I took part in a focus group of pregnant teenage girls enrolled in Medicaid who are participants in a separate citywide program that matched each girl with a doula, a birthing coach, to help her better connect to the healthcare system and prepare for motherhood. One conversation still stands out. Paraphrasing her almost 20 years later, one of the participants said with exasperation near the end of our time together, "Look, I love my doula and my doctor, and I appreciate all the help they give me, but I've slept on a different couch almost every night for the past 3 weeks, and that's why I'm having a really hard time." The limits of our programs expressed in the statement of that teenager are clear. She needed stable housing. What we had were doulas. She probably needed both. Her personal struggle captures the truth that years of public health research on social determinants of health has revealed. The primary drivers of health and well-being are income, education, community and family support, personal choices, environment, race, and genetics, while healthcare services contribute to a much lesser extent. Yet our healthcare system is built on the tenuous logic model that health insurance leads to access to effective healthcare services, which then leads to health. We are so beholden to this common wisdom that even though the Institute of Medicine estimates up to 30% of all healthcare spending is excess cost, we now spend almost 18% of our paychecks, payrolls, and government budgets on healthcare services, while we fall further and further behind on health status compared to the rest of the world. David Kindig, one of the country's leading public health researchers, recently wrote that for all our health spending, mortality increased for women in 43% of U.S. counties between 1992 and 2006, with no correlation to medical care factors such as health insurance status or primary care capacity. He calls for a robust strategy to address this appalling trend, and I quote, "Such a strategy would include redirecting savings from reductions in healthcare inefficiency and increasing the health-promoting impact of policies in other sectors such as housing and education." He goes on to say that each county, not each state, each county needs to examine its outcomes and determinants of health to determine what cross-sectoral policies would address its own situation most effectively and quickly. Yet Medicaid today operates under the default position that different populations and geographies face similar challenges, and equity in health insurance benefits is the goal of the program rather than improvement in population health. Medicaid currently treats states more like subcontractors operating at a discount than partners contributing over 40% of the bill. Deviations from the norm require state plan amendments and special waivers. This may give the illusion of accountability, but promotes neither quick nor effective local solutions nor cross-sectoral solutions which consider public health, education, housing, employment, food security, personal responsibility, and community action as important contributors to achieving better health and well-being for individuals and communities. The truth is there are few, if any, long-term population health goals currently negotiated between states and the federal government, so it is no wonder that we cannot agree on Medicaid's value. In addition, for all the federal efforts to manage expenditures through maintenance of effort requirements, limiting state revenue maximizing strategies, and focusing on fraud and abuse, the program continues to grow while access to health services suffers. I believe there is a developing bipartisan interest among states for flexibility to manage programs locally in exchange for more accountability, for improved health, and more predictability in expenditures at the state and federal level. I ask you to consider the proposals both before you and in development that would accomplish this goal. Thank you.
Chair thanks the gentleman. I will begin the questioning and recognize myself 5 minutes for that purpose. First, if you listen to many, you would think that all it took for our most vulnerable to be healthy was a Medicaid card. Yet, as Ms. Verma notes in her testimony, despite more spending, a Medicaid card does not guarantee access or quality of care. We know how difficult it is for states to customize care in a way that makes sense for each enrollee, not under a one-size-fits-all approach. And I believe the best way to improve the care of the 72 million Americans on Medicaid is through local action on the ground in a way that empowers states to work with stakeholders, providers, and patients. Ms. Verma, states often ask the federal government to cut the useless red tape that strangles innovation. Would you be specific? What specific bureaucratic hurdles are at the top of your wish list that you would like to see removed for states in an effort to improve care and reduce cost?
Thank you for the question. I think first of all, there's got to be some sort of a triage process that if there are routine changes, changes in rates, changes in benefits. So these are routine changes that some changes shouldn't require permission from the federal government. And I think we need to understand or to define what requires permission and what requires just informing the federal government that the state is making a change. So that would be the first one. I think the other piece in terms of, especially around innovation and around waivers, is to have some very defined criteria about how these waivers and state plan amendments are going to be evaluated, what the timelines are. I think it's very important for a state, for planning purposes, to be able to know if they submit a waiver, when they can expect to receive a response from the federal government, and also how that's going to be evaluated. I think reciprocity is also important, and I think if a waiver has been granted to one state or a state plan amendment in one state, that should be applied to another state, and that would also reduce some of the timelines there.
Mr. Keck, do you want to add to that list? Specific bureaucratic hurdles.
Yes, sir. First, I want to echo exactly what Sema said, is that reciprocity is important. We spend a lot of our time trying to figure out what other states have negotiated with their regional office or with the federal office for the exact same problem we're trying to solve. And many times we know that what one state has been told is permissible, our state has been denied. I think deadlines are important. We run on a state fiscal year, and when I need to respond to my legislature's budgeting process and their requirements to implement policies, I cannot do that very effectively when we operate on such long timelines with the federal government. I have a waiver issue that is being resolved right now that's taken 5 years to work through the system, and it involves $3 million worth of federal money, but it's taken years to negotiate and hundreds, if not thousands, of hours of staff time. And then finally, template changes. I believe there are a series of routine changes related to rates, related to quality measures, and so on, that states are fully capable of making on their own. It's actually rare that they get denied, but we spend many, many months and many, many man-hours responding to questions and so on. And again, being on a state fiscal year where we have to get changes implemented on a timely basis, it adds significant problems in our operations.
If you'll continue, Mr. Keck, many private employers and insurers have successfully lowered health care costs and improved patient outcomes through value-based insurance design, VBID. States have often asked for greater flexibility to offer VBID plans to Medicaid enrollees. What is South Carolina doing to ensure patients can achieve better health outcomes?
We are strong believers in the VBID concept, and actually we are the first state to work with the University of Michigan Value-Based Insurance Design Institute on implementing a VBID program in Medicaid. When we first met the folks that run this program, it was at a Millbank conference, and they were talking about the possibilities for VBID to work in state employee benefit programs. And along with one of my state senators, I raised my hand and said, well, what about Medicaid? Because Medicaid is one of the most important payers in the country, if not the most important. And they said, well, we don't do anything with Medicaid because the restrictions are so strong, and Medicaid folks don't contribute to their premiums, and they generally don't have copays that are enforceable, so we've just ignored it. And we pushed them during that 2 days and said, you can't just ignore it. We have to be able to build these concepts into Medicaid. The problem is they're generally one-sided. When you talk to VBID folks, it's a set of carrots and sticks, and they have different effectiveness in different situations. But unfortunately, generally in Medicaid, it's all carrots, and sometimes you need sticks. But right now, we're generally stymied. There's been some recent flexibility that's been granted by the federal government, but related to copays, but we're still convinced we need to go much further. And so in the next several months, we'll be approaching CMS with some of our ideas out of the VBID concepts.
Sure, thanks, gentlemen. Now I recognize the ranking member 5 minutes for questions.
Thank you, Mr. Chairman. I wanted to ask some questions of Dr. Thompson. You and I both have a number of concerns about some of the proposals to convert Medicaid to a block grant program or a system of per capita caps. While a block grant or per capita cap would save federal dollars by cutting payments to states caring for vulnerable families, those dollars would be saved on the backs of the most vulnerable members of our communities. In addition to the very real risk of beneficiaries being subject to reduced health care coverage and increasing personal health care costs, you also commented in your testimony that both of these proposals are likely to curb innovation. So could you explain what you mean when you say that these proposals will curb innovation, and also share your thoughts more broadly about the potential impact of these proposals?
Sure. Thank you, Mr. Co-Chair. Our healthcare system is incredibly complex, and I think what we see in short-term fixes are essentially what has been around for a long time, a desire for an easy fix, which rarely works in a complex situation. We have found that when we bring to the administration, and it has not mattered which administration, a approach that is inclusive of the needs of the low-income and vulnerable population, that's part of a long-term state strategy and that moves the system forward, we have been able to work through the regulatory challenges that are there. It is not always with the speed, and I think there are some of the comments by Ms. Verma and Mr. Keck that could be incorporated, are being incorporated by this administration on streamlined waivers. But I think if we don't take the root problem that our payment system is causing us to have a growth in health care that does not equal value or outcomes, then we are not going to have a quick fix that increased flexibility. We will squeeze the balloon in one place, and it will open up in another place, probably on state budgets or at the expense of the vulnerable and poorest of our citizens.
Now, in the end, won't capping federal support for the program merely shift costs elsewhere onto private businesses, patients, and providers, as well as state governments? I mean, you sort of suggested that, but if you could just answer.
Sure. This was what led our Republican leadership in part to take advantage of the Affordable Care Act. We have 25% of our Arkansas 19 to 64-year-olds that are uninsured. We have 40%, approaching 40% in some counties. Those individuals are not well. 50% of our population has a chronic condition. They're seeking care. They're using the emergency room in an inefficient way. And so by taking advantage of the Affordable Care Act, but importantly, tying it to our payment reforms and putting it in the private sector with the new cost sharing and co-payments, which we intend to push on and expand, we hope that we can actually design a new and sustainable healthcare system inclusive of Medicaid, and one that rewards providers for the care that they give and achieves equal high-quality care for all, regardless of income.
Thank you. Can I ask you, what was your experience as far as the flexibility, responsiveness, timeliness of CMS, the Centers for Medicare and Medicaid Services, when you applied for the state plan amendment for this?
Our state plan amendment went through in roughly less than 2 months, and this was from our inception to our successful achievement. It was, like Mr. Keck mentioned, important to be timely because we were concurrently running rules and regulations in our General Assembly. So we had to get both General Assembly support through rule and regulation and federal government support. And I think it's important for the feds and for the local General Assemblies to recognize those are often in concert, not totally separate issues. But we successfully got approval to have upside and downside risk on our providers within 2 weeks of request from the Center for Medicaid and Medicare Services.
All right. Thank you very much. I yield back.
Chair, thanks, gentlemen. Now recognize the Vice Chair of the committee, Dr. Burgess, 5 minutes for questions.
Thank you, Mr. Chairman. I'll try to make good use of Mr. Pallone's time that he yielded to me. Mr. Keck, I just got to ask you, for the good of the committee and our general knowledge, to spend just 2 seconds and tell the committee about what a doula is.
A doula is essentially a birthing coach that's of the community that generally she, but sometimes he works in to help.
Not a medical person.
Not a medical person.
So
a
not a midwife.
That's right.
Basically someone who daubs the forehead and says it will be all right. Is that correct?
Well, and also helps a woman connect with a healthcare system that is sometimes very difficult to navigate.
So is it correct to think of a doula as sort of a navigator, the precursor to a navigator?
I would consider them a community health worker, but to help navigate the health system because it's so complex.
And no disagreement there. And in fact, so good to have all of you all at this hearing. I cannot tell you the number of times we had hearings in 2007 and 2008 where you wondered where Mitch Daniels was when we were having all the discussions how to provide more for less. And you correctly identified Governor Daniels as being a leader in this issue, and he found that something magic happens when people spend their own money for health care, even if it wasn't their own money in the first place. Would that be a correct observation of the Healthy Indiana program?
Yes, that is correct. I mean, within the Healthy Indiana plan, participants are required to make contributions into an account. The state also funds that account, and then they use those dollars to cover their first $1,100 of health care services. And if they complete their preventative health care, then at the end of the year, then whatever money is left in that account rolls over and it decreases the amount that the person would have to pay in the subsequent years. And so we've had great results, lower emergency room use, higher generic use.
And this is the Medicaid population, not the state employee population that also was written about in the Wall Street Journal. Is that correct?
That is correct.
And what kind of savings did you achieve in the Medicaid program with Healthy Indiana?
I think what we've seen in the Healthy Indiana program in terms of savings is a real shift in patient behavior. We've seen patients...
May I interrupt you there for a moment, because that's an important point. In the Commonwealth Fund, and I don't generally agree with everything they talk about, but a few months ago they talked about the concept of an activated patient being one where healthcare expenditures were reduced. And essentially that's what you found, isn't it?
That's correct. I mean, I think that so many of the policy changes or regulations are aimed at providers, they're aimed at insurance companies, pharmaceutical companies, but we sort of miss the point that the individual has a very significant role to play in controlling healthcare costs. And that's not just for commercial populations, but even the low-income population. They are perhaps the best consumers of a dollar. They've had experience stretching a dollar. And I think when you empower them, that they start to make decisions about where to seek their health care, how to seek care in more appropriate ways, and seeking more preventative care.
Yeah, I liked everything about your testimony except that you were way too nice. And you need to be a little harsher in your assessments and saying there's trepidation about the future fiscal sustainability. Governors are scared to death, and I could use another word there, but I'll be nice. They're scared to death about what is going to happen by taking on this obligation. The federal government has proven itself to be an absolutely unreliable fiscal partner when it comes to health care. Ask any doctor who takes Medicare out there what has happened to their reimbursement. Let me just for a moment, you've identified something that is, I think, unique to Healthy Indiana, and that's the participation in the preventive programs. Is that a correct observation?
That is correct.
And the reason that that is so important, of course, is we will all talk about it here in glowing terms, that an ounce of prevention is worth a pound of cure. And so we're basically paying for that ounce of prevention, but we want to see the pound of cure. It's important because I'm told by my staff that the total federal spending over the next 10 years, combined federal and state spending over the next 10 years for Medicaid, is $7.5 trillion, $750 billion a month. I mean, that's a phenomenal amount of money. If we could even bend the cost curve just a little bit with preventive care, that ounce of prevention, that's a hell of a pound of cure. Let me just ask you this. What is Indiana doing as far as Medicaid expansion is concerned?
Well, I would defer to the state of Indiana to answer that officially, but I think that in the comments that I've read, I think that Governor Pence has indicated that he wants to understand what the future of the HIP program is before he can make a determination about what his position will be on the Medicaid expansion.
Thank you. Mr. Chairman, I just have to observe that I was at the second day of the Supreme Court oral arguments, and the discussion from the Solicitor General was repeatedly, it's the cost of these free riders that are driving up our health care. No, we reimburse so poorly in Medicaid that the patients can only do what they've always done, which is go to the emergency room, the highest point of contact. If we expand the program, we're going to expand the problem. I'll yield back.
Chair thanks the gentleman and now recognizes the distinguished ranking member of the full committee, ranking member emeritus, Mr. Dengel. 5 minutes for questions.
Mr. Chairman, I thank you for your courtesy and I thank you for holding this hearing. Medicaid is an important and timely topic, especially as we are about to greatly expand eligibility for the program as a part of the Affordable Care Act. Some of our colleagues here continue to ask for more flexibility for states to experiment with new and innovative methods of care. However, much flexibility already exists in the program, and many states are making significant changes using this. These questions are for Dr. Thompson, Surgeon General of the state of Arkansas. Doctor, I want to commend you for your helpful testimony. Doctor, did Arkansas recently implement the Arkansas Payment Improvement Initiative after receiving approval from the federal government? Yes or no?
Yes, sir.
Doctor, how long did it take for Arkansas to get that approval?
We worked 3 years on the development within the state, but the approval itself was relatively rapidly received in two
What
months.
does that mean? How relatively rapid?
2 months after our request.
Okay. Doctor, did this new initiative begin to transition away from the fee-for-service models towards a more value-based payment model? Yes or no?
Yes, sir.
And I happen to think, and will you confirm or deny this, that that's the direction we're going to have to go, because one of the things about our system is it's broken because we're paying for work done and not for results achieved.
I believe we must align the financial incentives for the outcomes that we want, not for the services that are provided, and I think that's one of the fundamental issues that has yet to be resolved in our healthcare system.
Thank you. Doctor, have the reforms implemented in Arkansas resulted in cost savings which can be quantified, yes or no?
Through the first 3 quarters of the year since we implemented this, we have seen a dramatic reduction in growth in the Medicaid program. It is lower than it has been in the last 25 years.
Would you submit this for the record? I gather the answer to that is yes.
Yes.
And would you please submit that for the record?
Yes.
Because I've got a lot of questions and very little time. Doctor, could you now please submit for the record a detailed explanation of the initial results following the implementation of this new Arkansas plan, please?
Be glad to.
Doctor, in your testimony, you mentioned that nearly every state has a Medicaid waiver and that there are currently 381 active waivers. Is that correct?
To the best of my knowledge, yes, sir.
Seems to me that the states currently have a viable existing pathway to get some flexibility under Medicaid. Do you agree with that statement?
I agree that they have that for flexibility.
Now, this leads me to questions of how many of the reforms proposed in a recent report issued by my good friend Chairman Upton and my other good friend Senator Hatch, entitled Making Medicaid Work. This report proposes to eliminate the medical loss ratio provision in the Affordable Care Act, which gave the consumers over $1 billion in rebates in 2011. The report also suggests that we repeal the maintenance of efforts provision in ACA, which would allow the states to restrict eligibility for the program and would reduce access to care. Finally, instead of turning Medicaid into a block grant, as has been proposed in years past, this year the proposals are a per capita cap on Medicaid spending. Now, Doctor, would this new proposal still result in the loss of coverage and benefits for beneficiaries? Yes or no?
Well, sir, I think the report that you allude to has several recommendations that I would concur with. The three that you identified, I would agree, have potential problems for the states. Per capita block grant to the states in the face of escalating health care costs that are not contained is a cost transfer to the state for future rate increases on health care.
Should scare the hell out of the state, shouldn't it?
My advice to any governor for a block grant is watch out, because you're getting a transfer of responsibility without control of future rate increases. We have to control the cost increases on health care before we can actually transfer fiscal responsibility or block off fiscal responsibility in the Medicaid
now, Doctor,
partnership.
Do you believe that the per capita cap would actually cause innovation by the states, or would it cause a disruptive nature which would place consumer protection of our most vulnerable citizens at risk? I gather you agree with that statement, yes?
I have concerns, and I think share those with others, that caps of any kind without a long-term strategy to assure quality while maintaining cost is a risk to the beneficiary, and it's a transfer of financial and responsibility risk to whoever is being capped.
I'm going to make a quick statement and ask this. I have the impression that our system is broken because we're paying for work done and not for accomplishments and for completion of assuring health for the people. And that we are trying to figure a way to transfer from the current system to a system which recognizes the need to get results as opposed to just paying for work. Now, Dr. Verma and Dr. Thomas and Mr. Keck, do you agree with that statement? Yes or no?
Yes.
Yes?
Yes.
The reporter doesn't have a nod key, so you got to say yes.
Yes,
no.
I do.
Have you all agreed with that?
I'll be the third to agree, yes.
Thank you. Mr. Chairman, I thank you for your courtesy to me.
Chair thanks the gentleman, and now recognize the gentleman from Illinois, Mr. Shimkus, 5 minutes for questions.
Thank you, Mr. Chairman. Dr. Thompson, I want to follow up on a little of Mr. Dingell's, your little discussion there. You said how many waivers you asked for? 380? 380?
No, that's the total number that are active across the United States from the most recent information we had from the Center for Medicaid and Medicare Services.
And how many? And so you all have submitted.
We have 12 active.
You have 12, and were those 12 active waivers all adjudicated or decided in that 2-month window of approval?
No, some of those waivers took much longer. Some of the waivers, as Mr. Keck alluded to in the past, have taken years to get a conclusion on.
Go back through your timeline. Developing your program by the state of Arkansas took how long?
So specific to the payment improvement program, which is the most current experience that we have, our Medicaid expansion will be this summer's experience. We started off with advice that Mr. Dingell alluded to. My advice to the governor was our fee-for-service system was broken 3 years ago. So we spent 2 or 3 years working with both the public and private sector. We have Medicaid, we have Blue Cross, we have Qual Choice of Arkansas. We have had Walmart as a self-insured company join because of their interest in changing the way the healthcare system works. Last October, we had Medicare join in our patient-centered medical home effort. So we have been developing this over the last 3 years. This summer, because we were changing the way that we were going to incentivize providers to engage with patients to increase the individual accountability of patients and also the outcomes accountability for the providers, we needed to get a state plan amendment from the Center for Medicaid and Medicare Services. We applied I can't remember if it's June or July, but within 2 months had approval from CMS to implement those changes, and we started aligning different incentives on providers in October.
So going back to this, so if there's 300 nationwide, 380 on average, 7+ waiver applications per state in the process, just on the simple math. My interest is, obviously, I'm from the state of Illinois. My personal opinion, we've done a very poor job, and what the state did last year, $1.6 billion of cuts to Medicaid program and established a moratorium on expansions for 2015, even though then we increased enrollment by 15%. and by the beginning of 2013, the state had a funding gap of $3 billion. Just last week, the state received yet another credit rating downgrade. It's our second. This is all the cost of a burden of states that are pension and Medicaid benefits. These are real life stories. So Illinois has now another credit downgrade, which means the cost of borrowing goes up. So if you were in the position of in the state of Illinois, because we're going to expand its Medicaid under Obamacare, bringing on new applicants to a system that's already spending $5 billion more, is already expanding our roles, what would you suggest the state of Illinois do? Let's go left to right.
I think you have to
rapidly, because my time is
okay. I mean, I think you need to take a look at managing care, put more managed care. I think looking at expansion without addressing the core issues and where they're spending their money. I think they need to explore different innovations, value-based purchasing that we've talked about, some sort of a reform on how providers, but I think it's also very critical to include the individual in that.
The individual has to be in the
individual has
process
to be part of the equation.
As a service or as a cost.
Exactly. So individual.
Dr. Thompson?
Sorry.
I'm just going to try to get quick.
My quick advice to any governor, including my own, was expansion without efforts to contain cost is a remedy for budgetary as well as state failure.
I'll take that. Mr. Keck?
I hesitate to make a suggestion for Illinois, but
please, we could get any help we can
We
get.
want to meet our commitments, and I think we're not meeting our current commitments. And what we've told our legislature is we have to pay for our current commitments before we expand.
And just finish up with Dr. Thompson again on this. So the way Arkansas has approached this, since Obamacare has really, we're buying off expansion with a promise of federal dollars, in which we will then walk away from the new expansions after that. So your bet is you're going to have a reformed system within your state that's able to carry the increased Medicaid individuals past the time frame when Obamacare and the beneficial additional dollars are gone.
We undertook payment improvement 3 years ago, so that predates our expansion that will go into effect this year. Your premise is correct. It is not just for the Medicaid program, however. It is that we think our private sector, that our business sector, that our economic attractiveness will outpace, with all due respect, our sister states around us, because we're going to both expand and get coverage in place. At the same time, we are reforming the payment system to make sure that it is sustainable.
I appreciate it. Thank you, Mr. Chairman.
Chair, thanks, gentlemen. Now recognize the gentlelady from California, Ms. Capps, 5 minutes for questions.
Thank you, Mr. Chairman, and thank you all for being here today and for your testimonies. As we know, Medicaid is a critical program. It serves over 70 million families, seniors, and individuals with disabilities. I think it's important to keep in mind that it is a safety net for these people who are otherwise shut out of private insurance, either because it's unaffordable, unavailable to them, or it doesn't cover the benefits that they need. So we know that individuals with Medicaid are more likely to receive preventive health care and less likely to have medical debt than their uninsured counterparts. Medicaid, like private insurance and Medicare, is trying to confront the same challenges of improving quality and cost. So a dialogue today about improving the system to provide cost-effective, high-quality health care to many of these individuals who need it is really a valuable discussion to have. But I think we must be mindful about exactly who will be impacted by the decisions that we make or that Congress makes, and if we are truly improving care or just passing the buck to states, persons with disabilities, seniors, and struggling families, in other words, the vulnerable. We have a responsibility, I believe, to make our best faith effort to improve the system on behalf of these individuals while protecting their access to affordable care. With the flexibility provided through Medicaid, a number of states have initiated quality improvement activities to improve access to preventive services, increase chronic disease management and prevention, and address population health. So Dr. Thompson, you're here because the Arkansas Medicaid program has had great success in collaborating with healthcare providers and the Arkansas Foundation for Medical Care to improve patient quality of care and health outcomes. what are the quality issues? I know you've talked about this, but if you don't mind restating them, the quality improvement initiatives, and how do you rank your success to date?
Well, our state is burdened with a heavy risk burden in our population.
Yes.
50% of our citizens have a chronic disease. Our QIO, the Arkansas Foundation for Medical Care, has worked closely with our providers, both physicians and hospitals, particularly on the hospital side, reductions in readmissions, improvements in outcomes after delivery, more recently efforts to reduce premature delivery. That then results in negative neonatal outcomes. So there are real interest and opportunities with providers if the engagement is right, if the incentives are aligned correctly, to move the system forward in a positive way.
So that's exactly what I was hoping we could get at. Could you speak to the success of this program and the ways that you've seen care coordination improve across the Medicaid providers? And do you believe this program, that what some of the models that you're using could be enhanced and expanded so that other states could take advantage of it?
Well, what we have done is we've taken what was a quality improvement effort, which is what I just described, and we have now tied the payment mechanism for providers to reinforce quality outcomes. We have actually taken, for example, our hip and knee surgeries, and we have said there is a responsibility of the surgeon from 30 days before to 90 days after for the outcome. And now their payment is tied to what the outcome for that patient is. It increases engagement with the patient, it increases the decision process of the team, and we think it will reduce the cost and inefficiencies in the system over time.
Wow. And you've seen some indications that it is working?
We're starting to see provider behavior change, both within the OB episodes, within the hip and knee episodes, within the hospitalization episodes. And as we talk to providers, almost every association says there's 20 to 30% waste in the system, but nobody has ever aligned the financial payment mechanisms to have providers lead in eliminating that waste.
Boy, that's a good thing to discuss, ways to do that without making it seem punitive and punishing for doctors. Well, anyway, I wanted to get one last question on the table. The initiatives that you've undertaken, have they all been done within the current statutory and regulatory framework of the Medicaid statute? In other words, what kind of waivers have you used? How much have you been able to do straightforward?
Well, I hope they're all within the regulatory and statutory framework
Yes.
of the current Medicaid program, or somebody's in trouble. No, we have been able to do it. I think it is not an easy path. I think the current administration is streamlining that path, and our recent experience has been much better than our past experience. Again, that's not with any prejudicial interest on prior state or federal administrations. I do think that when a state has a desire to come with a plan that safeguards the beneficiaries and their needs, that fits into a long-term state plan, and that moves the Medicaid system as a whole forward, is a prerequisite for successful negotiations between the federal and state government.
Well, thank you, Mr. Chairman. This was good to hear. Appreciate it.
Chair, thanks. The gentlelady. Now recognize the gentleman from Louisiana, Dr. Cassidy. 5 minutes for questions.
Thank you, Mr. Chairman. Dr. Thompson, I noticed you're wearing Arkansas colors in your tie, so I'm an LSU guy. I couldn't help but notice that. Listen, I was very intrigued by your testimony. You say that the state of Arkansas is contracting, I gather, on a per beneficiary payment to managed care companies. They are at upside and downside risk, correct?
We do not use a managed care mechanism, so it's the state itself that is at risk for cost increases or cost savings.
But there's a per beneficiary amount, because you mentioned there's an upside and a downside.
The upside and downside risk that I mentioned was actually what we have now shifted to our episodes of payment to providers. Providers now have the responsibility, upside and downside, for the outcomes of the episodes, as I mentioned.
Now, I'm sure they protested, but on the other hand, as you point out, they've been able to achieve cost savings and increased efficiency.
Actually, our providers are relatively, I will say with some caveats, supportive of our effort. They knew the system had to change. They did not want another bureaucratic layer put on top.
Got you.
And they said, look, we'll take responsibility for that clinical.
Don't mean to interrupt, you just limit time. So, if you will, you're capping the amount of money that goes per episode. And I guess the point I'm trying to make is that whenever my colleagues on the other side tend to suggest that any sort of cap whatsoever is going to be deleterious, in reality, y'all have capped and you've actually seen success.
In actuality, sir, we have not capped anything. The providers.
So when there's a bundle of care payment, that is not really a capped amount, but rather can be.
It is not a capped. It is not a capped.
So there's not a true upside and downside, I guess.
There's a target that the lead quarterback for the team will have financial impact, but every member of the team is still paid.
I understand they're still paid, but if they exceed that target, do they lose money?
Not the members of the team, but the quarterback does.
The quarterback does. Yeah, so there is for that particular quarterback, there's a cap.
There's a target.
Well, I think we must be using different terminology, because if there's a downside for him, then effectively there's a cap.
Again, sir,
There could be no cap.
be glad to share, but we have not capped any provider's payment.
Okay.
We have
Now,
set goals
now,
if
Mr.
they share in the gains.
If,
when they meet
then somehow I don't understand how your downside works. But let me ask, Mr. Keck speaks about how really on a county-by-county basis per somebody, there should be variability. I have to imagine our states are similar, that in the Delta, there's a different patient population or different structure of health care as opposed to Fayetteville.
And without question, different healthcare needs, different.
So that said, who's better equipped to make that determination, the county or the state official, or rather somebody in Washington, D.C.?
Well, I would say it would be a local provider, local community.
Seems right, right. So I think when Mr. Keck speaks about the flexibility, I think that's something we can all agree on. Next, I would ask, on the other side, there's a lot of defense of the status quo in terms of Medicaid. But Dr. Thompson, I'm sorry, would you agree that, are you aware that some states really manipulate the Medicaid system in order to maximize federal payments to their state? For example, New York, which has half the population of California, gets 33% more federal payments than California.
I am aware of different strategies that states have employed that don't necessarily tie directly to pay.
Yeah, some people call it gaming, and that seems to be the legal way to describe it. I'm struck that even the Democratic witness would agree that there's some problems with the status quo, which it seems as if the other side doesn't want to admit. In fact, I noticed that you're nodding your head yes when Ms. Verma stated that when Medicaid empowered patients to consider cost savings, there is actually good results that result from that. Could you accept what Ms. Verma was saying?
Well, I think our approach through our Medicaid expansion will have cost sharing on individual patients.
So I was struck that Mr. Waxman suggested that if any of that occurs, it's going to be terrible for the patient. But in reality, I think I'm hearing from the witnesses that there's actually some positive things that happen both for the patient as well as for cost savings.
But it is with safeguards on the patient.
Of course, everybody accepts it as case safeguards, but on the other hand, status quo is status quo. And right now, if we can do something different, we may improve. I think even our Democratic witness is not agreeing with Mr. Waxman on that one. Mr. Keck, you accepted that, you seem to suggest that the states could accept some limitations on payments as long as they had flexibility, and net they would come out better. Would you agree with that?
And that's how we pay our managed care plans. We capitate them and give them a lot more flexibility to negotiate rates, to change benefit structures. They take significant risk. We're able to put high accountability on them in terms of performance measures.
So when Mr. Waxman suggests that any cap whatsoever is unworkable and any flexibility given to the states to manage is going to be terrible for patients, you're saying no, that wouldn't necessarily be the case?
I don't believe that'd be the case at all.
And you've experienced in 2 states with high poverty levels, both Louisiana and South Carolina, so you really are where the rubber meets the road, not in ivory tower in Washington, D.C., but really where you have to see those patients in New Orleans get care. Is that a fair statement?
The rubber meets the road in both South Carolina and Louisiana.
Yeah. Okay, I'm out of time, and I yield back. Thank you.
Chair thanks the gentleman, and now recognize the gentleman from Texas, Mr. Green, for 5 minutes of questions.
Thank you, Mr. Chairman. I know our committee started out with concerns about the reimbursement rates. I assume reimbursement rates in Indiana, South Carolina, and Arkansas are the same as in Texas. Reimbursement rates for Medicaid are set by the state.
That's correct.
Okay, so, and I know the pecking order. You know, if you have private insurance here, you have Medicare here, you have Medicaid here. And I found out when we started mobilizing our resources or our reserves in Houston 10 years ago, how low TRICARE reimbursed our physicians and hospitals. But that's set by the state. The other issue is that I don't think that in 3 years the federal government's going to walk away from now at 3 years it's 100%, and after that it's 90% reimbursement. Is that correct? I wouldn't quite call that walking away from the Medicaid responsibility, but anyway, just so we know that. I have a district in Texas, very urban district, and in one of the highest uninsured rates in the country. I'm disappointed our legislature did not do something with expanded Medicaid, similar to what Arkansas has worked on, and every once in a while I'm jealous of Arkansas's football program too, but when they beat a Texas school, but I would hope we would see that change. One of my concerns is the churning rate, and in Texas we make folks come in for Medicaid every 6 months, and even for S-CHIP program. Do any of your states have a longer term for enrollment in 6 months. Does Indiana have 6 months or a year? Arkansas or North Carolina?
We make people redetermine every 12 months, but if they have a change in status, they're supposed to self-report.
If they have a change in status, but you don't make them show up and redo it every 6 months.
No, and we also we do redeterminations through express lane eligibility, which we found to be very effective.
What about Arkansas?
Ours is 12 months. I think important to your churning question, our expansion effort, which will use private plans, we believe will largely eliminate the churn process entirely. People will stay in the plan will re-enroll them, they will not have to touch the Medicaid program.
Ms. Verma, what about Indiana?
Yeah, in Indiana they have continuous eligibility, so there's no,
I only have a few minutes.
There's only a change, but they do have 12-month continuous. If there's a change, it has to be reported.
Sure, that seems reasonable. If it's a change, you have the opportunity to go in and check it and do that. Congressman Barton and I both identified that as one of the concerns we have, because as a former state legislator, I also know we can quantify, if we do it every 6 months in 1 year as compared to a year, how much money we can save over that period of time, making Medicaid recipients come back and sign up. And I've seen the lines out in front of the offices. So hopefully we'll look at that piece of legislation to have that, unless it's changed circumstances. That's the issue. Let me talk about Arkansas a little bit. One, again, congratulations, Dr. Thompson, on some of the considerations. What do you think the consequence of not expanding Medicaid would have been for Arkansas?
Well, I believe our healthcare system was at a tipping point. I mentioned earlier we had 25% uninsured statewide. We had some counties that were approaching 40% of the 19 to 64-year-olds. These people were consuming care but not able to pay for it. Our providers were not able to stay in business to provide it. I think we were at a tipping point that the opportunity under the Affordable Care Act, which I won't speak for or against, but as an implementer of the Affordable Care Act, I think it led a safe line, particularly for our rural health care providers where the uninsurance rates were much higher.
Well, and again, I'm concerned because our percentages are the same as Arkansas, but with a lot more folks that are losing that kind of opportunity to have it. Mr. Keck, South Carolina has both a lower rate of Texas for churn and because you do it on the year. In addition to Mr. Keck, in addition to the CHIP law, Congress enacted a provision provides bonus money for states that go out and exceed expectations in enrolling low-income Medicaid children. I understand South Carolina received CHIP bonuses in 2011 and 12. Would you agree that the bonus program is good and positive incentive for states to find and enroll lower-income children?
Yes.
Do you know how much money the South Carolina program received? Because all that money goes back into Medicaid, I assume.
We don't have our latest bonus calculated, but we're committed to, when our legislature sets an eligibility limit, we're committed to getting everybody enrolled under that eligibility limit.
And again, I know private sector employees offer health care benefits, continuous coverage for their employees as long as they remain there. And again, Mr. Chairman, I would hope we would look at considering that bill on that Congressman Barton and I have. And I yield back my time. Thank you for being here.
Chair, thanks, gentlemen. Chair recognizes gentleman from Pennsylvania, Dr. Murphy. 5 minutes for questions.
Thank you, Mr. Chairman. Welcome to the panel, particularly Dr. Thompson. I've come from a long list of Murphys in Pennsylvania who are physicians, Garland Murphy, Doty Murphy of Springdale, and I don't know if you know any of those, but if you do, please extend my greetings to them. I wanted to ask you first, Dr. Thompson, some questions about where Arkansas stands. Your state has recently agreed to this Medicaid expansion proposal that carries with it the assumption that HHS will let you have approval. Now, my understanding is HHS and CMS have consistently noted publicly that nothing is approved for your state. In fact, Administrator Tavener recently said before the Senate Finance Committee, quote, "We haven't approved anything," unquote. So could you outline for this committee what Secretary Sebelius, in coordination with OMB, has explicitly agreed to allow Arkansas to do in 2014 as it relates to individuals not currently enrolled in your Medicaid program under 138% of federal poverty level?
Sure. First, let me deal with the approval issue. Approval for a state-federal waiver is actually a financial contract. So until it's signed by both parties at the end of the process, there's no approval. Where we are in our process of what we call the private option on Medicaid expansion, which is to take Medicaid dollars and use them essentially for premium assistance on the private health insurance exchange, is an accepted concept. Premium assistance has been used before by Medicaid programs in a limited way to buy private employer-based coverage when it was more efficient, effective, and cost beneficial to the Medicaid program. We are extending that in concept to be premium assistance for all newly eligibles on the newly established insurance exchange. We think that by harmonizing both the cost sharing on individuals above and below the Medicaid eligibility line, that we will educate our Medicaid eligibles on how to use the healthcare system. As they then go up into the health insurance system, they'll be better informed and prepared to use the healthcare system in a more appropriate way. We will eliminate churn, as we talked about before, because people will be in a health plan and probably stay in a health plan year after year. The health plan will want them to. So where we are now is we have a conceptual agreement of where we're going. We're working through the specifics of what will end up being a streamlined waiver to get to the essentially contractual agreement between the state and the federal government on guarantees of coverage and the financial aspects of the agreement.
Let me add one other thing that you can provide for us as a follow-up question. That is to provide us with updated projected state and federal 10-year costs if Arkansas did not expand and thus the individuals above 100% of federal poverty level acquired private coverage, and 2, expanded and every individual would be under traditional Medicaid below 130% of federal poverty level, and 3, to move forward under the legislature approved proposal. But that's information I'd like you to get for us in the future.
Sure.
Real quickly from Mr. Keck, I think in your testimony you said that 30% of health care is waste?
According to the Institute of Medicine and many other sources, that's the latest estimate.
Well, let me ask you this. Under the way when Medicaid dollars come through in the federal government, state level, and other things, what % of that is spent on a wide range of administrative costs that never get to actual patient care? Do you have some estimates of that? And under the current way things are spent, do you have any idea?
Well, if you just look at the Medicaid expenses in terms of administering the program, on the fee-for-service side, it's about 3.5%. On the managed care side, it's about 9.5%, with a percent of that at risk. But that additional expenditure is because they're managing the care better.
So under that, so when that is done, rather than that being seen as 3 times the cost, and they manage the care better, is there an actual difference in healthcare, improved healthcare outcomes when they specifically coordinate that care of that patient?
Absolutely. I mean, on an annual basis, our legislature requires that we compare the cost of our managed care programs on a per member per month basis to that of the fee-for-service program. And even with the additional cost, managed care is cheaper than fee-for-service, and it produces better outcomes in terms of our HEDIS quality.
I mean, one of the things I look upon when the managed care movement hit in the 90s, I didn't care much for it because much of that was managed money and not managed care. That's why I like to look at it as more as coordinated care, where physicians and nurses are in charge of decisions. Let me ask another way this can be coordinated. The federal qualified community health centers. Can you tell me how your state may work with them with Medicaid to make sure, because I'm concerned a lot of people on Medicaid don't really have a primary person they keep going to as their home. Too often their lives are disrupted. They go from person to person to person. Can you give me as an example if that's something you work with in your state to help coordinate that?
Absolutely. I mean, one, in a broad sense, we are working with all primary care providers. We're now making patient-centered medical home incentive payments. If you become certified, you get a per member per month bump to encourage people to become certified, and eventually we'll convert that into broader care management payments to these folks. But specific to the federally qualified health centers, I think when we talk about the rates of uninsurance, we forget that in most states we have very robust networks of federally qualified health centers that were chartered to serve these folks, and we spend a lot of money on them and are a great resource. And this year in South Carolina, we're actually putting quite a bit of additional investment, probably the largest single investment that's been made by the state in the history of the federally qualified health centers, to expand the presence of those and their ability to work with patients.
Thank you, Mr. Chairman.
Chair thanks the gentleman. Now recognize the gentlelady from Virgin Islands, Dr. Christensen, for 5 minutes for questions.
Thank you, Mr. Chairman. And just for informational purposes, I noted that from a Kaiser report that there were, in 2001, there were 36.6 million people enrolled in Medicaid. And by 2009, there were as many as 62.9 million. That was the year that President Obama took office, just for informational purposes. But Dr. Thompson, as a person who worked with some of my colleagues when we were drafting the Affordable Care Act, who advocated for everyone to participate in the exchange, including those who had previously been Medicaid, I was really pleased to read and hear from you that you are transitioning to premium assistance. And so you're really demonstrating flexibility and the support over the last 3 years of CMS and the department. So I want to applaud Arkansas's creativity, and I want to say that I enjoyed being in Little Rock last year when the University of Arkansas and the Clinton Foundation joined several of us in having the conference on health disparities in Little Rock last year. So thank you for that. Are you using navigators of any kind as you plan that transition? Because many of the Medicaid beneficiaries would not have much experience in going to a private insurance market.
Sure. Since the action of our General Assembly, we've actually increased the number of navigators our health insurance department planned to hire on a short-term basis to reach the lower income communities, communities of color, those that are Medicaid eligible in a more successful way. We are also looking at information we now have inside of the Department of Human Services, for example, parents of children that are on the Our Kids program, so that we may have already determined who is likely to be eligible for the private option, if you will, through the exchange, that we've already done an income eligibility assessment.
And when we were talking about this back 4 years ago or so, they were concerned about wraparound services in Medicaid that might be lost. Are you seeing that your Medicaid patients would lose anything by going to the exchange?
This is one of the issues that we are in negotiations with CMS about. All of the Medicaid eligibles are eligible for wraparound services. However, a majority don't use those. They're able-bodied working individuals that are just low income. And so it's those individuals that we anticipate putting into the private market, having them have a private experience, not be, if you will, managed by the state. But for those for whom the private market is not going to be the best mechanism, we will retain them in the state Medicaid program, assure them of the wraparound services, and make sure that they get the guaranteed benefit as required under federal law.
Oh, great. Thank you. And in the wake of the Newtown shooting, again, to Dr. Thompson, last fall and the recent shootings in Santa Monica, our nation remains concerned with access to mental health services for people with mental illness. Congress passed mental health parity legislation in 2008, and additional provisions were included ensuring parity for mental health services in the Affordable Care Act. A significant barrier to access is, of course, not having health insurance. So how do you anticipate the Medicaid expansion will help Arkansas to address the issue of access to mental health services, and what challenges do you see in the state for improving that access?
You know, I believe the requirements under the Essential Benefit Plan of the Affordable Care Act and our actions on the Medicaid program to buy into that Essential Benefit Plan will singularly help both the mental health and the substance abuse community, because it brings to true parity, finally, the financing mechanism for those services. It will have an effect on our workforce. We're going to have to look at the organization of our mental health workforce to make sure they're in the right place, because rural Arkansas does not have as deep a bench when it comes to that workforce. But I think financial barriers have been the #1 reason we haven't had the right providers in the right place at the right time, and through this we're trying to solve that first barrier.
Thank you, and I'm sure you've seen this report by NAMI, the National Alliance for Mental Health, entitled Medicaid Expansion and Mental Health Care. They quote an analysis by SAMHSA that shows that if all states proceed with expanding Medicaid, as many as 2.7 million people with mental illness who are currently uninsured could get coverage. That includes almost 1.3 million with serious mental illness. And Mr. Chairman, I'd like to submit this report for the record.
With that objection, so ordered.
Thanks. I also want to agree with your statement, Dr. Thompson, that caps of any kind is a risk to the beneficiary. And I'd like to add that I'm adding up from my own point of view, that not setting the FMAP according to the jurisdiction's average income also presents a risk. And I want to thank the committee for, one, increasing our cap in the territories, but not remove, although we did not remove it entirely, but I'm still asking the committee to help me in passing my bill to change the match to give the territories state-like treatment. It costs nothing to the federal government. but it saves lives and decreases the risk for our beneficiaries. Thank you. I yield back the balance of my time.
Chair thanks the gentlelady. Now recognize the gentlelady from North Carolina, Mrs. Elmers, for 5 minutes for questions.
Thank you, Mr. Chairman, and thank you to our panelists today for this important subcommittee hearing. I am representative of North Carolina. North Carolina has chosen not to opt into the Medicaid expansion, and I applaud that decision that Governor McCrory and the state legislature made. Just to quote Governor McCrory, the federal government must allow North Carolina to come up with its own solutions. It is a $13 billion program, and he refers to it routinely as broken, and because of that does not want to expand a system that is in much need of fixing. So with that, and again, I appreciate your testimony today on this issue. I have a question for Ms. Verma and Mr. Thompson in relation to what Director Keck has basically said in his testimony, notes that he sees an opportunity for bipartisan agreement that states need more flexibility to manage programs locally in exchange for more accountability to improve health and reduce costs. Ms. Verma and Mr. Thompson, do you agree that Washington's approach this far with Medicaid is outdated, and do you also believe that states have the ability that they can, with outcome measures and greater flexibility, improve care and reduce costs?
Yes, I do.
Thank you.
I think the whole healthcare system is going through a great transition, and that states are bringing innovative ideas. I think this administration in the new Center for Innovation has 41 different models for states to choose from. And I think the partnership between the federal and state government should be maintained, because that's how we're going to get the whole U.S. healthcare system to a different place.
Okay. I also have a question, Mr. Keck, for you. In South Carolina, I know that South Carolina is working with the CMS right now on integrating physical and long-term care services for 65,000 enrollees. Can you speak to the status of those negotiations and maybe give a little bit of a timeline where we may go with that in implementation?
Well, we're very supportive of the dual integration to manage Medicaid and Medicare patients together under a cap, I might add, per member. We have a good working relationship with the Office of Dual Eligibles and are working hard on that. But to be honest, it's a very, very slow process. I think that is the experience that most states have encountered, and it's primarily because of working with the particular restrictions that Medicare has on the program. But we hope to get to a memorandum of understanding by the end of this month or the end of July, and go live by the middle of 2014, which is about 6 months behind schedule. But we think it's a good effort, and it's a needed effort. The dual eligibles are a very large portion of our expenditures, and for both Medicare and Medicaid, we have been doing great disservice to the taxpayers and to the individuals to not manage these folks together.
Yeah, I agree. Thank you so much. And my last question, I have about a minute left. Ms. Verma, can you elaborate a little more on some of the innovations that your state is making right now to improve upon the Medicaid system?
Okay. I work with a lot of different states, so kind of hard specifically, but I will take the Indiana example, because I think that's the one that I've worked with extensively. And I think other states are looking at Indiana because of some of the innovations that it's done. I think what they've really done, as we discussed earlier, is trying to empower the individual and have the individual as part of the equation. I think some of the cost-sharing policies are where Indiana and other states are seeking waivers. And it's not, the cost-sharing policies is not to burden the individual or to, try to ration care or limit them from getting care. I think it's to incentivize them and to empower them to be a part of the equation. And so I think that that's where a lot of states are very interested in those types of programs. that really do put that individual in the position of focusing on prevention, focusing on outcomes. And I think a lot of the programs, you know, that are based on the physicians, we've talked a lot today about outcomes and physician outcomes. Well, the individual has to be a part of that. The physician's not going to be able to achieve those without it. And I think outcomes are also not just for the physicians, but even for states. We need to hold states accountable for outcomes as well. And so we need to align the providers, the individuals, and states together in the same direction.
Thank you so much for your testimony, and I see my time has expired. Thank you, Mr. Chairman.
Chair, thanks the gentlelady. Now I recognize the gentlelady from Florida, Ms. Castor, 5 minutes for questions.
Well, thank you, Mr. Chairman. Thank you very much to the panel today. Over the past decades, the federal-state partnership that is Medicaid has evolved, and it's changed into more of a managed care system. More states have adopted managed care. CMS has been very granted great flexibility for states to tailor managed care Medicaid services. I'm concerned, though, that we lose some control to the managed care company, some accountability. Could you all give me your opinion, identify the most effective waiver conditions, oversight initiatives in the states to ensure that our tax dollars actually go to medical care and health services and not to excessive administrative costs or to excessive profits for insurance companies and HMOs?
Start with that. I think there's a lot of strategies that states can take in their managed care contracting, and it all has to do with how that contract is set up. I think they can put in medical loss ratio requirements that would limit the amount of dollars that are spent on administration and on profit. There are outcome measures, and I think that's one of the main differences between state government and contracting out with a managed care company is that you can require outcomes of managed care companies. You can have standards for access, standards for maternal and child health outcomes in terms of low birth weight babies. You know, whatever a state wants to attach to the contract, they can in terms of outcomes. And that's something that you don't have with state government. If it's a regular fee-for-service program within a Medicaid program, there's no accountability for the outcomes they achieve.
I would concur with Ms. Verma. I would add, I think it's important to start with what the beneficiary's needs are and make sure that the outcome indicators, the expectations of the managed care plan, a managed care plan that covers both an urban and a very rural area, network adequacy is an important issue so that access issues become important. And I think in the 35 states that have large rural areas, an important aspect is how are we going to actually manage care in a decentralized, relatively fragmented healthcare system.
I would agree with both those statements. We've had much better luck actually assuring network adequacy in our state, working with our managed care companies because they're able to negotiate individual rates. And so if they're having a hard time getting a doctor in a particular area, they can pay more. We can't do that through our fee-for-service program. So we're very specific and spend a lot of time understanding our network through geocoding and so on. And we also put our plans at financial risk now for outcomes, and they have both incentives and they have withhold.
So if they drop the ball, if they're not providing the services, are there penalties built into the waiver conditions or the contracts? And are you aware of states really holding their feet to the fire and providing proper oversight?
We don't operate our managed care under a waiver. But through the contracts, we do hold their feet to the fire, and the amount of potential penalty that we have this year on our managed care plans could potentially be their entire profit margin, and so we are moving forward very aggressively with that. Some states are even more aggressive, but we clearly measure our outcomes and our cost per member per month. And we know that managed care, coordinated care is making a difference. We think there's a long way to go in terms of better managing care on the ground, but this is the tool to do it.
Dr. Thompson.
I think we're taking a little bit different, maybe a next generation approach with our payment improvement initiative. We're asking the lead provider to manage the clinical risk and to have financial incentives upside and downside while we're retaining the actuarial risk, kind of the chance that somebody who has a hip replacement also has a heart attack back with the insurance company or with the state. So I think both are actually trying to put alignment of financial incentives with the outcomes that the state, the Medicaid program, the federal government desire. And I think we need to probably accentuate the sharpness of our knife that we start looking at.
Does Arkansas, do you all have a managed care waiver for the elderly population, skilled nursing, and services that keep folks out of? Because Florida is about to embark on this, privatization of managed care for that population. It's new to us. All of the providers are scared to death. They don't want to go through a gatekeeper. What has your experience been?
We have not used a third party, a managed care entity, to exercise that option. We do have a waiver, our home and community-based service waiver, that allows the family to use the allocated resources that would have been spent inpatient in a nursing home for skilled or family-assisted living to help them stay at home. So we have a waiver in place. It is actually highly sought after by our families to keep their loved one at home. It does not use a third-party manager in a managed care type of arrangement.
Thank you very much.
Chair, thanks, gentlelady. I recognize the gentleman from Virginia, Mr. Griffith, 5 minutes for questions.
Thank you, Mr. Chairman. I appreciate that. According to the CBO, Medicaid will cost the federal government $5 trillion over the next 10 years, with as much as $638 billion of that directly linked to the expansion of Medicaid from PPACA. Recently, the governor of my state, Governor Bob McDonnell, laid out the need for vast reform to make Virginia's Medicaid program more cost-effective before the Commonwealth can consider an expansion. The state legislature set up a system where they can consider expansion if these reforms are met. And there were 5 tenets that he laid out for Medicaid reform. 1, service delivery through efficient market-based system, including more managed and coordinated care. 2, reducing financial burdens to the state by getting an assurance from the federal government that expansion will not increase the national debt. 3, maximize the waivers that currently exist to achieve administrative efficiency through streamlining of payment and service delivery. 4, obtain buy-in from healthcare stakeholders in the state for statewide reform. And 5, achieve greater flexibility by changes to federal law, including more value-based purchasing, cost-sharing, mandatory engagement in wellness, and preventative care, the development of high-quality provider networks, and flexibility around essential health benefits. Whew, it's a mouthful. The bottom line is these reforms that Virginia is now discussing on par with the plan laid out by Chairman Upton and Senator Hatch to provide states with more flexibility to implement their Medicaid programs in a way that makes sense for them while better controlling costs. Ms. Verna, how do you feel about these Medicaid reforms that Virginia is currently exploring? What can we do to help the states better serve the vulnerable populations that need Medicaid while giving the states the flexibility that improves the quality of their program, promotes access, and gets costs under control?
I think that Virginia has all the right elements there. I think they've covered the span of identifying incentives for providers and individuals. But I think the key part there is that they're going to need flexibility from the federal government to implement those pieces. So that'll be a critical component. But I think they have the required elements of a reform package.
So you think that is a good
I think it's a good approach. I'm glad to hear that they've also included the individual in that piece. I think that's important. They've got the providers, they're looking at the benefits, and I think they also recognize the important role that the federal government plays in this to making that happen.
Now, as a part of that flexibility for the states, how do you feel about a situation where, yes, we want to reward folks for doing the right things, but what if they can consistently do the wrong things? Do you think that there ought to be some kind of a stick that can also be applied in that flexibility if somebody continually goes to the most expensive healthcare provider because they just don't seem to care that they're running up the costs?
Absolutely. I mean, I think but you have to use those sticks appropriately. You have to be mindful of the population. I think that the carrots and sticks work differently with different populations. I think a disabled population, those are a little bit harder to apply.
Absolutely.
However, as we're talking about Medicaid expansion and able-bodied individuals, I think those are probably more appropriate populations that those could be effective.
And that does make sense. For everyone, there's always a lot of debate around when states can and cannot implement cost sharing. From your perspectives, when does cost sharing work, and what can be done to really allow the customization of cost sharing at a local level?
I think cost sharing needs the most work. I know CMS did put some proposed rules out that increase the cost sharing levels. I think it's very rigid structure. It only requires copays. There's no opportunity to enforce premiums for people below 100% of poverty. There's no flexibility to do value-based, where you would be able to vary the copays depending on the types of services. And I think the enforcement piece is critical. I mean, what happens with copays and the way that they have it structured is that it ends up being a decrease in the provider reimbursement because providers can't collect it.
And let me go to the other side. I only have about 45 seconds left.
I'll add to that. My hospitals would be remiss if to that particular question about cost sharing, I didn't mention that we need to do some reforms to EMTALA, because EMTALA has turned into sort of a blanket reason to be able to use the emergency room without regard for appropriate use.
Sure. Dr. Thompson?
I think we're on a path to change. The administration's proposed rule, which we have incorporated into our private option, is on the right path. I think it is a complex system, and at some point, cost sharing, if you're only making $6,000 a year, does become a barrier to access. The other piece that we've had to work with on our providers and our workforce strategy, if you're working an hourly job and the doc's only open 8 to 5, you're going to end up going to the emergency room. So we need our docs having after-hours clinic and weekend clinics, or people are going to do exactly what you would expect them to do. They're not going to lose an hour's wage to go to the doctor in the middle of the day when they can go to the emergency room at night. So this is part of a total system change. It involves workforce, it involves access, and most importantly, it does involve finance.
I thank you all for being here. Mr. Chairman, I yield back.
Chair, thanks, gentlemen. Now recognize gentleman from New Jersey, Mr. Lance, 5 minutes for question.
Thank you, Mr. Chairman. I yield my 5 minutes to Dr. Burgess.
I thank the gentleman for yielding. Dr. Thompson and Mr. Keck, really to both of you, there seems to be a good deal of antipathy toward the fee-for-service system, and yet the fee-for-service system is what many doctors have grown up with, what we rely upon. I would submit, I realize that the Medicaid system is not directly analogous to the food stamp system, but I suspect that if you tried to do a food stamp system that was not a fee-for-service based, taking the basket to the marketplace and not paying a fee for every service that you loaded into the cart would be problematic. Is that an unfair observation?
Well, I think fee-for-service is not universally the cause of all our problems, and there's actually within the system places where you want to use fee-for-service to encourage volume and productivity. And there's other areas where you want to use bundled payments and capitation and so on to encourage parsimony in the use of services.
Dr. Thompson, do you have an observation on that?
Yeah, I would just offer, our payment improvement still pays claims in the same way that we did under a fee-for-service system. So we are still paying providers for the care at the point of delivery when they have care. What we have done is we have put a quarterback on the team that now has the responsibility for how the outcome.
Let me ask you a question about that. Is the quarterback always a physician? You reference prenatal care. Is the quarterback always the OB doctor in that instance?
The quarterback, as has been decided by our multi-payer effort to date consistently, is the provider has the most influence on the system, the most ability to make change, and the most financial interest. It is usually the physician. With respect to congestive heart failure readmission rates, it is the index hospital, because they know when they're discharging the patient and how to get the patient plugged back in.
They own all the doctors now, so there's no, it has to be the hospital. There is no other entity that to be identified. Well, when I think about the food stamp system and the Medicaid system, when I go to my market at home and behind someone in line who has the Lone Star card, which in Texas is the food stamp, the way that's utilized, there oftentimes will be a brief discussion between the cashier and the individual buying the products, and they've identified out of a large bill, here's a certain number of dollars of things that you've picked up that are not covered, and you'll have to pay cash for those, and there's no effort to embarrass the person. It's just simply they pay the dollars that are required. Why would it be hard to construct a system like that within the Medicaid system? That is, the patient comes, and in fact, some of the bill could be borne by the patient. Now, you referenced the harshness of co-payments or people who would have to pay some of their own money, but there seems like there's got to be a happy medium there where some additional money can be brought to the system by the person who's ultimately utilizing the system.
Well, let me use your food stamp example. Our payment improvement effort is like sending a nutritionist through the aisle with the patient, with the individual. So we're actually putting a nutritionist with that food stamp recipient as they buy their food. To your issue on sharing, that's exactly what the Affordable Care Act does through the exchange. We set an essential benefit plan. There's a tiered level of co-insurance, co-risk that decreases the lower a family's income is. What we have done in our state is we have layered one more layer underneath that says for the poorest of the poor, we'll put some cost sharing in place, but we're going to offer some protections.
And let me ask you a question about the concept of premium support, because, I mean, and to some degree that's gotten a bad rap here in Congress. It's called a voucher and it's talked about in a derogatory term, but it sounds like you're using that to your advantage. The premium support is part of your so-called private option. Is that not correct?
We believe in our bipartisan, actually our Republican leadership and our Democratic governor believes using the private sector with competition for provider rates and with competition for patients, essentially, is the best way to consider expanding Medicaid, because it is not a traditional state Medicaid expansion. It does not have the cliff of people then wanting to stay on Medicaid and not moving to private insurance.
Let me ask you this, because Dr. Murphy asked a question about the Federally Qualified Health Center. The liability coverage is handled differently in a federally qualified health center. Texas, several years ago, experimented with providing the first $100,000 of liability coverage to a provider who was doing a certain percentage of Medicaid in their practice. Have you looked at that in Arkansas as a possibility? You need to bring providers into the system. Most of us recognize that it is that first $100,000 of liability that is where the real vulnerability exists. Medicaid patients do sometimes carry a higher liability risk. Have you looked at that in Arkansas?
We have not looked at that as a way of recruiting providers. We have a relatively high provider participation rate because we use electronic payment within 72 hours of service delivery. So our discounted prices we have combated with increased cash flow and responsiveness to treatment. But that has been our tool. I think your suggestion would be very open to our medical society and probably our Medicaid program.
Is that something you're willing to look at?
Be glad to.
Thank you. Mr. Chairman, I have a series of questions on Medicaid as the payer of last resort. I guess the appropriate thing would be to submit that for the record, because I'd like each of you to respond to that. The General Accountability Office did a study back in 2006 and looked at the states that were collecting that were covered under Medicaid but also had simultaneous coverage under either an individual plan or a group plan. And for each of your states, it's about a 10% rate of people who are covered, have dual coverage. And I'd just be interested in your thoughts as you expand managed care, are we going to make that problem worse? And how can we get at, I mean, when you talk at $750 billion a year, 10% of that is a lot. So we really ought to we can't just leave that money on the table. If it's owed by private insurers, it should be paid by private insurers. But I will submit that in writing. I'd appreciate each of your responses to that. And then finally, Mr. Chairman, I would like to ask unanimous consent to put into the record an article from the New England Journal of Medicine entitled "The Oregon Experiment: Effects of Medicaid on Clinical Outcomes."
Without objection, so ordered. That concludes the questions from the members. The members will have additional questions. We'll ask them to submit in writing. We'll ask the witnesses to please respond promptly. Thank you very much for your testimony today. And let me remind members they have 10 business days to submit questions for the record. And members should submit their questions by the close of business on Wednesday, June 26th. This has been a very informative hearing. Thank you very much. Without objection, the subcommittee is adjourned.